In terms of the government giving extra subsidies to the public option, anybody who understands the public option and is advocating the public option understands that it's absolutely critical that this competition that we want to set up needs to be fair. And by fair, we mean everyone plays by the same rules. The insurance regulation rules, in other words, who you can accept or not accept, what you can charge them in terms of their premiums. The rules all have to be the same for the public option and the private plans. In addition, the subsidies have to be equal for the public option and the private plan, so that there's no advantage from an individual's perspective of going into one or the other. That if you qualify for a subsidy based on your income, you get the same subsidy regardless of your choice. I know that some conservatives are worried that this is a conspiracy to sneak into single payer through the back door. But really, honestly, I don't believe that's what it is. I believe that it's saying, listen, we know that we can have much lower administrative costs under a single payer system than we can under a private insurance system, where physicians are having to hire multiple staff to deal with the literally hundreds of different health insurance policies, each have different rules, and that we know we can streamline that administration under a single payer plan, and that is more efficient, and they're going to have a tough time competing with that. We also know that if they do allow the government to negotiate on prices for medical devices and for pharmaceuticals, that the insurance companies may not have the same advantage in terms of bargaining for those prices. And so again, it may be difficult for them to compete if the government is willing to exercise that purchasing power. But the idea is that as long as the playing field is level, as long as the rules in terms of how you operate and what you charge are the same, that at least you've made it fair at the starting point. And if there are, in fact, advantages that the government has in terms of efficiencies, then all of us, it seems to me, would want to encourage entrance into, or encourage people to go into the more efficient system to save us money, and so we can continue to provide a comprehensive set of benefits to everyone. So that would be my argument, that yes, you're right in one sense that there is opportunity for efficiency if you have a huge pool at the national level and it operates like a single payer system. But that's the whole point, is to try to force the private sector to be as efficient as the government.
And one way in which they could do that is further consolidation on the private commercial insurance side. So there's 7 or 8 major carriers now, and so they could consolidate further, and we might have 2 or 3. You'd have, the public, and then you'd have United merge with WellPoint Anthem or something like that, and go toe to toe. And that's the American way. Right?
Yes, it is. I wanted to make one other point. I had talked a little bit about who can go into the pool. And right now it's just the uninsured and people who work for small employers are the only ones who are eligible. And there's a big debate right now about who else can go in. And there's a population out there that we cannot forget about. It's the population that Michael Moore talked about in his film Sicko. And these are people who have insurance, but it's really lousy insurance. And they think they're covered until they get sick. And then they find out that their insurance company simply doesn't pay for even a fraction of their costs. And as we know, more than half of bankruptcies in this country are due to medical care costs, and most of those are for people who actually have insurance. These people are called the underinsured, and estimates are, I think, and this is low, maybe there's 25 million of them out there who have insurance, but they have these skinny benefit packages with these high deductibles and this high cost sharing. And it seems to me that it's important to give those folks a choice too, and not force them to be locked into this lousy package that their employer offers. And it's called the Free Choice Amendment in the Senate Senate Finance Committee right now, and I think it's really important that group get the recognition that it needs, because underinsurance can be just as bad as having no insurance at all.
So I'm curious about your reaction to a proposal that I've made, because I agree that I believe that the public option would be most important in the short run to low-income individuals.
Yes.
Because the private insurance market is very good at providing competitive options for lots of different benefit ranges for middle-income, high-income individuals. If you're a low-income individual looking for a low-premium option, it's usually something that's high cost-sharing. But as we've seen across the Bay in Healthy San Francisco, the city is able to put together a health insurance option based on our safety net clinics. So it's not all the sort of top-rated hospitals and clinics in the world, but they're still giving very good care, and they're able to put together a plan at much lower prices with almost no cost sharing in Healthy San Francisco, and it's primarily low-income individuals who are selecting into it, people under 100, 200% of the poverty line. And I've suggested a compromise, because the public option is so controversial. If you had a public option that was just available to low-income individuals, then that's an intermediate step. It would not be as threatening to the insurers, and it would help out the low-income individuals. Now, some people will say that, well, if it's not perfect, then I don't want it. And I say, let's not let the perfect be the enemy of the good, and let's help out these low-income individuals and give them a chance to buy into some other benefit policies that are based on safety net providers.
Well, and I would argue that just because you have a low income doesn't mean you shouldn't have a choice. And if the subsidies are equally available, if you choose the private plan or the public plan, your income shouldn't be a determinant of what system you're in. I think it's wrong to force people just because of income into one system or the other.
I'm not forcing them. I'm saying giving them a choice. So everyone who's low income right now and not qualifies for Medicaid has to go out into this exchange or the private market, and the options aren't very good for them. I'm saying give them the option to buy into a public
But the way
plan.
the exchange is designed is that your subsidies based on your income, so that if your income's only 200% of poverty, you would be getting a huge subsidy, and you'd get the same subsidy regardless of if you choose the public plan or the private plan. So you preserve that choice regardless of income. And I think equity is really important.
I'm
here.
agreeing. Let's do that.
Okay.
What I'm saying is let's offer the public option as a compromise just for low-income individuals.
Because
and this is the start.
Well, because low-income individuals are less healthy. You know the income gradient better than I do. The more wealth and income you have, the better your health status is, and the lower it is, the poorer your health is. And so you would be pooling sick people in this pool, and you would. Yeah, oh, right,
Yeah.
okay. Well, what's the R-square on your regression coefficient for explaining?
No, on average, I don't need a good R-squared. I need on average to get it right. I need on average to get it right. I don't need a perfect R-squared. Risk adjustment is behind the scenes in all
We will
of
agree to
these bills.
disagree.
Yeah, it is. It is. Oh, okay. Do you want to go to the audience, or?
I say keep going.
Thank you for that. I think we're going to bring up Jackie Bender, and we'll open it up to audience questions, so Jackie will be moderating that.